I'm Dr. Donald Jenkins. I'm the Trauma Medical Director at St. Mary's Hospital here at Mayo Clinic in Rochester. And in that role, one of the things that we have set as a goal for our trauma center is to work very closely within our trauma community. And that community is the southern tier of Minnesota. Those are where the majority of our trauma patients come from. And so we've been on an outreach mission to coordinate trauma care across the 20-plus level 3 and 4 hospitals, trauma centers that are out there in southern Minnesota, to try to improve on trauma outcomes. A couple of the things that make this a challenge are the number of deaths that happen related to trauma. As many people know, but maybe not most, trauma is the #1 killer of people under the age of 45. In Minnesota, about 2,200 Minnesotans die every year of trauma. That's right around 200 a month. 7 a day are injured and die as a result of those injuries. And for every one of those injured, there's another 9 or 10 Minnesotans who end up hospitalized because of the severity of their injuries. And so our goal in working with our trauma centers out there in the southern tier of Minnesota is to try to improve outcomes so there'll be fewer deaths, fewer hospitalizations in that trauma patient population. So we've been working on a number of initiatives. One of those things that we take quite seriously here at St. Mary's is quality assurance and performance improvement. We look hard every day at the care we render to our patients. And even though we have fantastic outcomes, we're always looking for something that we can do to make an improvement. It's not good enough on a day-to-day basis. We can't sit back and say that we're doing everything that there is to be done. We can find areas, opportunities for improvement. Everything from human performance to system level issues. And so what we have undertaken, because we have so many capable people trained in performance improvement for trauma care, and so few of our small, low-level rural trauma centers have enough people with this training, we have set out to create a trauma performance improvement training program specifically aimed at those rural centers, low-volume trauma centers in the southern tier of Minnesota. We've now held our third in a series of 5 seminars related to performance improvement for those centers. In the first 2 seminars, it was highly regarded, and people learned a lot, as they have now begun the redesignation process with the state to begin that next round of trauma designation. We have word from the state that in fact that training has taken seed in those centers. They're seeing vast improvements in the performance improvement programs at those trauma centers. Now, one of the things that when we look at trauma system issues, we work closely with the state. And a fellow by the name of Chris Ballard, many folks know him. He was a paramedic and then a nurse, and then the trauma the trauma designation coordinator for the state of Minnesota. Chris visits every single one of these hospitals as a part of the designation visit. And he has collected over time a compendium, a list of the top problems that plague these low-volume trauma centers. And we talked to Chris about that, and he helped us organize for the 3rd seminar. Now, that 3rd seminar was aimed at the development of practice management guidelines. We assembled in Red Wing a group of about 80 people who volunteered to come to this training program. 2 admitted that they had working knowledge of practice management guidelines. The vast majority had no idea what they were getting into, but they knew that this was important. We laid out the plan of the day, gave an excellent lecture from a visiting professor, professional from the Society of Trauma Nurses, Mike Glenn. Mike gave a fantastic introduction to practice management guidelines, what they are, why we would use them, how we create them. And then for the remainder of the day, that group of 80 people broke up into 10 groups. And we put down on that table the top 10 list of the problems that Chris Ballard had identified that were plaguing those trauma centers in their performance improvement programs. And each group made a different practice management guideline based upon the science that we had given to them in the lecture. We created some templates for them to use to create that practice management guideline. And lo and behold, 4 hours later, they had not only each group created a practice management guideline, but they had presented those guidelines to the rest of the groups, received critique, and when we walked out, what we had were 10 practice management guidelines, each one addressing one of the top 10 major issues facing level 3 and 4 rural trauma centers in the state of Minnesota. And we took those guidelines, we codified them, standardized the formatting, added some scientific evidence to them, and then brought them back to our Southern Minnesota Regional Trauma Advisory Committee. We went through the Performance Improvement Committee. Some of them went through the Pre-Hospital Committee. Some went through the Pediatric Committee. And those committees presented the first 4 of those finalized guidelines to the entire group. We made some minor modifications to a few of the guidelines, but each one was passed unanimously by the representatives of SmartTech for adoption by level 3 and 4 trauma centers here in southern Minnesota. We chose issues that we thought were easier issues to adopt at first. They wouldn't threaten anyone's notion of how to care for a trauma patient necessarily, but they would be good tools that any level 3 or 4 trauma center could adopt and help in the process of improvement across the continuum of care. From the moment that patient is injured in rural Minnesota, if they have an injury bad enough that requires trauma care at our level 1 trauma center, it's about 4 hours of time go by from the time of injury until EMS is notified, they get to the scene, they stabilize the patient, they transport the patient to the local level 3 or 4 trauma center. The patient is further evaluated and resuscitated. Identification of a problem that the patient has that is more than can be handled at that trauma center is made. Arrangements for transportation are made, and then the patient is physically transported from that regional hospital to our level 1 trauma center. 4 hours have gone by. And that's a lot of important things that need to happen in that first 4 hours to save that patient's life. And we're trying to help those level 3 and 4 trauma centers adopt the best practices that we can identify based upon evidence that these are the areas we most need to focus on. So far, we've had great reviews from the trauma centers that have evaluated those practice management guidelines, and they've adopted them. It's not a mandatory thing. This is an all-voluntary group. This group has gotten together because they want to do better. They want to drive down the trauma death rate in southern Minnesota. To do that, they are voluntarily looking at these guidelines, going to their medical staff and saying, could we adopt these? Should we adopt these? Should we modify them for our purposes so that it's more fitting with how we provide our care? But it's a great starting point. And this has been such a successful endeavor that the other 5 trauma regions in the state all want to put this symposium on, this seminar, in their region so that their hospitals can also benefit from it. Our plan for that is to take Chris Ballard's top 10 list, he's actually got a top 20 list, and use a few of the same that we already have developed, but branch out and take on additional problems that were identified. And have these folks that are at the working end of this equation. This isn't level 1 trauma center people telling other hospitals what to do. This is a group of people getting together, that 80 that got together in Red Wing, from level 3 and 4 trauma centers. They developed those guidelines on their own based upon their experiences, their acknowledgement of the patient needs, and what they could do in those centers. So to be able to take on even more of the problems that are affecting performance improvement and the quality of care rendered to trauma patients across the state is a huge endeavor. The folks in the Minnesota Department of Health and the trauma organization there are really excited about this opportunity. We've had the opportunity to speak with many national figures who have been instrumental in writing the book on performance improvement for trauma centers at the level 1 and level 2 trauma center level. And they've never heard of an initiative like this. To have an entire state potentially using one set of practice management guidelines for those regional centers of the people, by the people, for the people, if you will. And it's a truly amazing endeavor to see those folks come together. At the end of the day in Red Wing, we point blank asked the participants, at the beginning of the day, did you think you could possibly be walking out of here with a handful of practice management guidelines that you had written? And to a person, they all said no. We knew that they could do this. We know that they have that potential. It's just a matter of bringing it out in those folks. And it doesn't take much, because they really want to solve this trauma problem that we're facing in southern Minnesota.